Good morning, everyone. My name is Ellen Barra, and I'm a specialist with our Provider Outreach and Education team. On the call with me today, we have Aline Ziegler, who's going to be placing information in the chat and then also watching for your questions, your comments, that type of thing that are in the chat. And that's where we do want you to place your questions. So we'll go ahead and kind of jump into our presentation. The first thing that I have up on the screen is not something that you downloaded if you went into our live events webpage to download the presentation today, but it is information that we need you to know. The interactive voice response system, which is the telephone system where you can use your keypad in order to get information back from us, the eligibility functions on that will be removed as of January 1st of 2025. This is a CMS directive to all of the contractors. CMS indicated in their instructions that this had to be removed by the end of March of 2025, but that Max could remove earlier. So we are removing earlier as of January 1st of 2025. And what we have on your screen for you there is other eligibility resources. So you can go into the Secure Net Access portal, you can go into the direct data entry or the HIPAA eligibility transaction system, what's also called HETS, and then you can get that eligibility information back. Just a couple of housekeeping things to take care of. Number one, we want this to be a great customer experience for you today. So at the end of this presentation and a couple of times during the presentation, we will be placing a survey link within our chat function. We really want your feedback. One of my colleagues calls it the good, the bad, and the ugly. If you think we did a great job today, please let us know that. If there's ways that we can improve the presentations going forward, please let us know that also. And then at the top of the page, we've got a link there for you to our training center. This has your training materials, such as the presentation for today. It has upcoming events, additional webinars that we're going to be providing. And then we also include encore presentations on this page. Now, the reason we include those is we're aware that some of you, your offices may not allow you to access YouTube. You've got security concerns, policy concerns, all of that kind of thing. So we do keep these encore presentations on the website, which has an embedded player for you for 60 to 90 days. Kind of just depends on how many we get out there. And then, of course, the recording of the presentation will also be available on our YouTube channel, and it will stay out there until we determine to remove it or unless there's some information that has changed. And again, put any questions or comments that you have into that chat. The next thing that we have is just a disclaimer for you. This information that I'm going to provide for you here today is as accurate as we can make it as of today. CMS rules do change often. If you've been with Medicare for any length of time, you're aware of that. The questions that we respond to today will be responded to based on the information that you provide to us. Medicare rules and your documentation, especially for evaluation and management services, will determine that final coverage. And then at the bottom of that slide, we have a link for you to the CMS website that will provide you with the absolute most current information. The next thing that we have is just a CPT copyright notice. There are some procedure codes kind of throughout this presentation today. Medicare, the CMS agency, the Medicare administrative contractor, we don't own those codes or those descriptions. Those are owned by the American Medical Association. And so this copyright just reminds you of that, the fact that they own it themselves. So what are we going to talk about today? Well, we're going to talk about evaluation and management errors. So we're going to talk about errors that come from different contractors, and you can see a couple of them listed on this slide. The Comprehensive Error Rate Testing Program, or CERT, Office of Inspector General, or OIG, and then the Recovery Auditor, which is the acronym for that is RAC. And then we're also going to provide you with some of our internal data where evaluation and management services have either rejected as unprocessable or they have denied. And for our data, we'll talk about what that means, what you need to do next, etc. So let's talk about the CERT program first. And CERT really is a way for CMS, and then CMS, of course, sends those the reports and everything to Congress, but it's a way for CMS to determine an improper payment rate. And so what the CERT contractor will do is they will request a certain number of medical records each month for each contractor. I think right now they're requesting 100 medical records. And then they will evaluate that medical record to see whether or not the contractor, such as WPS, whether or not we paid that correctly. Now, all of the claims where the CERT contractor may request documentation does not necessarily mean that the MAC requested documentation also. But they are reviewing that documentation and then making a decision from there. Evaluation and management services represent about 40% of the total Medicare fee-for-service payment. Because of that, evaluation and management services do continue to rate high on the error rate itself. The presentations that we've done on evaluation and management service is to provide you with the information you need in order to bill correctly. And it all comes down to documentation. Does your documentation support the procedure code that you have submitted into Medicare? And then, of course, does that procedure or does that documentation support the medical necessity of the services that you have provided? If documentation is not received or it doesn't meet Medicare's coverage or coding or billing rules, whether we downcode it, we deny it, or we upcode it, all of that is considered an error. So some of the CERT documentation errors that we've seen recently has to do with time not being documented correctly. Now, the two places where this shows up more than anywhere else is in critical care services. And for critical care, you have to have at least 30 minutes of critical care time in order to bill that 99291 procedure code. If it's less than 30 minutes, then you do have to submit a hospital visit code, not the critical care code. When billing the 99292 procedure code, which is also critical care, you have to support a full 30 minutes past the first 74. So what this means then is that you would not use that 99292 code unless you had at least 104 minutes documented where you were providing critical care to that patient. The other situation where this comes up a lot is in discharge management services. Now you have discharge management for your hospital, and then you have discharge management procedure codes for your nursing facilities. Both of these have two codes. One code is 30 minutes or less, and then the second code is for more than 30 minutes. Well, if you're using that second code, such as a 99239 for the hospital discharge, the documentation has to show more than 30 minutes. If it doesn't, then of course Medicare is going to downcode that to the 99238 procedure code. And then in that next section on your slide, the documentation doesn't support the service. This could be where the CERT contractor has downcoded or where they have upcoded, where they believe that the documentation supports a higher level of service than what was actually billed. Medicare's Education on Evaluation and Management Services wants you to submit an appropriate procedure code for the work that your physicians and practitioners have provided for that patient. We don't expect you to bill a lower level of service. If you can support the higher level of service within your documentation, then submit that. And then another big error on the CERT contractor is no documentation was received. So a couple things you can do there. Number one, if you get the request, you need to respond to it and you need to respond timely. The other thing that you want to take a look at is your enrollment record. And do you have the correct address for your medical record correspondence address? This is where you want these requests for documentation to go. If you're not getting those requests, maybe they're going to another address, they're going to another department, check your provider enrollment record to see if that's actually what the issue is. The next thing that we have is part of a report, and this is a 2023 report from CERT, which goes back again to CMS and back to Congress. So this is for an established office visit. Now, one of the things you'll notice on here, if you look under the sample claim count on the far right-hand side of your screen, there's not a whole lot of documentation or claims or procedure codes that they've actually looked at. However, from the ones that they have looked at, this is the root cause of this. So you can see there, for an example, in that first line, it's incorrect coding. Documentation did not support the level of service that was submitted, and therefore they downcode it. Insufficient documentation, either we didn't receive anything back, or the documentation was unsigned. Documentation should be signed at the time of the service or shortly thereafter to allow for transcription. If for some reason the documentation is not signed, you cannot append or add a late signature. What you need to do in that situation is do an attestation statement. And that attestation statement is really a legal statement that says you agree with whatever documentation is there. And then again, under insufficient documentation, the documentation really was just inadequate to support the service. So if you look here on this slide, the E&M projected errors, okay, that's what this is talking about. So what they do, and remember we saw in that first line, there's not a whole lot of claims they're looking at, not compared to the universe of claims. But what they do is they take the number of claims that were reviewed, the error rate, and then they expand that to the universe of claims. Now, I'm sure there's a whole lot more math that goes along with that. Frankly, I don't want to know how they do that. However, look at that first bullet point. From 2023, the CERT contractor is projecting the errors for office visits established to be more than $1 billion. Well, CMS has to do something about that. That's part of the reason for that error report is so that CMS can establish what's going on with those services, and then make determinations as to what they need to do next. And then you can see the other ones listed there too. But that really is over $1 billion projected to be errors for established office visits. CMS can look at edits that they can possibly implement. They can provide instructions to the MACs on education that we need to do, etc. If you've been with Medicare for over 10 years, you probably remember this. In one proposed rule, what CMS proposed, now they have rescinded it, but they did propose that they would pay a single amount for all E&M. So for an example, whether your procedure code was a 99202, a 99215, what they proposed was they would pay one amount regardless of the level of service. They believed at that time that that would drastically reduce this error rate, not only the numbers and the percentages, but also the amounts. This was rescinded, and like I said, this was about 10 years ago, but CMS does have to take action on these reports. And so, there's a lot of different things that CMS can do. But what we want to have happen, though, is we want the claims to come into us correctly to begin with. So they're coded appropriately, the documentation supports it, etc. Another thing that we see is the Office of the Inspector General, or the OIG work plan. And so one of the things that's listed on the work plan currently is an audit of Medicare payments for emergency department services provided in non-emergency department sites of service. So the rule for emergency department services is that it does have to be provided in an emergency room. And there's requirements about hospital-based and available 24/7 and all kinds of different rules there. So what this means then is you would not bill an emergency department service that those category procedure codes if you're doing the service in an office or if you're doing the service in an urgent care center. The emergency department procedure codes are not valid there. So what you want to do then is to look at where did the service take place, and then based on that, what is the correct category of E&M service to actually submit? And then the second one is looking at physician relationships with other payers. So this could be a primary insurance, it could be the hospital organization that they're working for. It could be a lot of different things that actually where payment is going back to that physician from another entity other than Medicare. And then the OIG also, not only with their work plan, but they also do investigations. Now, this particular investigation is from 2010, but they continue to look at E&M. As you can see here, they identified over $6 billion in improper payments. That's billion with a B. That's a lot of money. Always document what the physician performed today for that patient. We've heard statements from providers such as, I always bill a high level of service because my patients are sicker than anyone else's. No, they're not. This is not an accurate statement. We've also heard, I only treat one particular diagnosis. Therefore, all of my patients, because of that diagnosis, receive the highest level of service. This also is not accurate. Your documentation must support the work that's provided for that patient on that day. Sometimes, even though your particular specialty may treat patients that have very intense diagnoses, today the patient's doing okay. So today you would not necessarily need that high level of service. So again, documentation must support the work that was provided on that date. The Office of the Inspector General is also investigating evaluation and management services connected to ordering of genetic testing, ordering of durable medical supplies, ordering of lab tests for patients. There have been multiple people who have been sentenced to prison, multiple people who have had to reimburse the Medicare program. This is a fraud situation. A call center contacts a patient. They're getting their Medicare information. They're then selling it to another provider who orders these tests. In addition to ordering these unnecessary tests, they're also billing for telehealth services. They don't see the patient, they're not treating the patient. In some cases, they don't even contact the patient. Then the order is given back to the call center, who then sells it to the lab or the durable medical equipment supplier. Approximately 10 years ago, I think, the Office of the Inspector identified what they called at that time Operation Brace. And this is where providers were ordering the DME braces, back braces, wrist braces, knee braces, etc. When when most of it was not medically necessary. At that time, the Office of the Inspector General identified over $1 billion in overpayments, both from the DME suppliers and from the physicians and practitioners. The thing about that is, though, this investigation has not stopped. It's still continuing. If you receive the Office of the Inspector General, if you receive their daily email, this type of situation shows up in at least 4 out of the 5 emails every single week, where providers are getting kickbacks, they're selling information, all of that kind of stuff. And then these labs and DMEs are billing for stuff that is not medically necessary for that particular patient. Next, we have information on the Recovery Audit Program. So this is another CMS contractor. And the way the recovery auditor works is they propose situations to CMS. So they'll say, hey, we want to look at whatever it is. If CMS approves, then the recovery auditor begins to perform auditing. This can be automatic, which means that they're not looking at any documentation. They're using system macros and things like that to identify situations where where they believe Medicare should not have paid, or they have complex auditing, which requires medical records. And again, you want to make sure that medical record correspondence address is complete and accurate in your provider enrollment. So look at the top one there. Visits to patients in swing beds, incorrect coding. Well, is the patient a skilled nursing facility patient? Are they a nursing facility patient? Are they still an inpatient? The biller or coder needs to identify the classification of that patient with the facility in order to bill correctly. So depending on the status of the patient, this could be a different procedure code and it could be a different place of service code. The improper payment comes when we're paying a non-facility fee and we should have paid a facility fee. The second one is similar in the fact that the patient is coming to the office when the hospital still has them listed as an inpatient. This again is incorrect coding based on the place of service and the procedure code, and then the difference in payment from the facility versus the non-facility payment. One of the issues that we see here quite often is that physician and practitioner claims come in a lot faster than the hospital claims do. So the physician claim comes in, we don't have a hospital service on record or admission on record, therefore we're going to pay that E&M. But then the hospital claim hits the processing system. Now we have to do overpayments. The providers have to go back, they have to refund money, they have to then correct the claim. So this is costing, obviously, the Medicare trust fund a lot of money, but it's also costing your offices a lot because then you're having to repay, you're having to rebill, you're having to investigate, etc. Ask the questions. If the patient's coming to you from a facility, ask them, what's the classification of this patient? So we've got two things listed on this slide. Number one, Medicare is starting what we call a targeted probe and educate for the procedure code 99214 for our J8, which is Michigan and Indiana Part B providers. Now, this one is a little interesting, and we just finished a webinar on this on October 1st, and this is available on our YouTube channel, and it's also still available on our website. We discussed the process and we provided some examples. Now, the interesting thing about this is that this actually started as a result of another targeted probe and educate on lipid panels. So we're requesting documentation on the order of the lipid panels. As we're evaluating that documentation, we're finding that providers billed the 99214, but the documentation really did not support it. So we're starting a specific targeted probe and educate on that procedure code. And again, it's for J8 Part B only right now. That doesn't mean that it may not expand. You can also see here that we have done data analysis, and we pulled this as of September 23rd of 2024. And this represents claims for dates of service that we had received June 1st through August 31st. Now look at the next two bullets. We had 116,000 over that unprocessable claims during that time frame. Well, an unprocessable claim really means that there was something technically wrong with it, with the claim itself, such that we could not make a payment determination. These are fixable. These are situations, and we'll talk about specifics here in just a second. But these are situations where you don't have to, if you get the claim incorrectly, you don't have to wait for payment. If you receive an unprocessable rejection, number one, you have to fix the claim and then you have to resubmit it. Well, that's just delaying your payment. And so Medicare doesn't want that to happen. Medicare's job, as a representative of the MAC, our job is to pay you correctly for the services that you provided. But we have to have a good claim in order to do that. And then you can also see here, we had 603 denials, 603,000 denials. Well, those are generally going to be things that you can fix on the front end also. And we'll talk about what some of those denials are and then how you can correct them before they ever come into us. So let's talk about unprocessable first. And remember, unprocessable means we have not made a payment determination, so the claim has to be corrected and then resubmitted. So the first one that we're going to talk about there is provider eligibility. One of the things we see is that the rendering provider number was not entered. So we have the group, we've got ABC Medical Group, but we don't have Dr. Smith or anyone identified as that rendering provider. You want to verify that your electronic systems are submitting that. You want to make sure, and that last bullet or the last two bullet points there, you want to make sure that Dr. Smith is enrolled as part of your group, because if the rendering provider and the group don't match, then again, we're going to deny as unprocessable. And then that middle section, the provider is not eligible. So the first thing you want to look at there is make sure there's no typos or transposition of numbers, anything like that, in the provider number that you have sent to us. And then the other thing you want to look at is to verify that that provider has been revalidated and therefore they're still eligible in order to submit services to Medicare. The next one that we have is patient eligibility. The name and the Medicare number have to match exactly. So even though you may call your patient Bill, if William is on the Medicare card, William is what needs to come into us. The second one there, the patient is not eligible. Not all patients who are eligible for Part B elect to take Part B. So you want to really look at the patient's Medicare card for both their Part A and their Part B eligibility. In addition to that, you want to utilize the self-service portal in order to determine that eligibility for your data service. And then the last one there, submit to another contractor. The Railroad Retirement Board is the more common one, and the patient's medical card will tell you that they're a railroad retired beneficiary, and that's in red on the bottom of their Medicare card. United Mine Workers is another common one, and this is where you'll need to talk to the patient or to use that self-service portal. That information's not on their Medicare card itself. So for the submit to another contractor, you want to investigate that. If you submit to us first, again, you're simply delaying your payment. We're going to deny, then you're going to need to submit to either Railroad Retirement or United Mine Workers. Unprocessable place of service conflict. This is one of the ones that we were talking about earlier. You're using, for an example, an office place of service code, but you're using a nursing facility place of service code. So if the patient is coming to you from a skilled nursing facility, but they're being seen within your office, you're going to use the facility place of service code or facility 2-digit code to identify your place of service, and then use the facility procedure code, not your office visit code, because the procedure code and the place of service code do need to match. Multiple evaluation and management services on the same day. There's two ways that this applies. One is when you're billing multiple new patient procedure codes. The rule is that if the patient has been seen previously within that previous 3 years by the same person or a member of the same group with the same specialty, it won't be a new patient. It will now be a subsequent patient. And then if you're seeing, the patient is being seen multiple times on the same day by either the same person or a member of the same group with the same specialty, you combine up that documentation. If the services are related, if they're unrelated and could not have been performed at the same time, then you can submit that separately. We are making some changes, and those changes will begin in December for non-physician practitioners under both of these two guidelines. We have a webinar that's coming up on that on November 21st. If that's not already advertised on our live events webpage, then it will be advertised within the next 2 weeks. If you're billing for non-physician practitioners, then I really encourage you to attend that. Another thing where we get unprocessable is in the units of service. And most of the time, this is going to be in hospital visits. So you're submitting the claim for the subsequent hospital visit, and you tell us that there were 2 services, but you give us 3 dates. Well, we can't tell for sure when those services were actually provided, and so therefore Medicare is going to reject that back. And then the second example, you give us 1 date of service or 1 unit of service, but now we have 2 dates. So again, we can't tell for sure when that service occurred, so we're going to reject that back. So you can fix it and then submit it. Another unprocessable denial has to do with modifiers. There are only certain modifiers that are appropriate for E&M services, and these are listed here for you on the screen. So we've got the 24, which is an unrelated E&M during a post-op period. We have a 25, which is significant, separately identifiable on the same day as another service. 57, which is the decision for a major surgery. FS, which is the shared and split service. And then an FT, which is an unrelated critical care service during a global period. So what you want to be looking for, number one, is a modifier required? There's a lot of situations where we receive a modifier 25 and it's not necessary. An example is an E&M service with a professional component or a global component of a chest x-ray. There's nothing in Medicare guidelines whatsoever that says you cannot do both on the same day. Where you're going to find those guidelines is in the Global Surgery Guidelines and in the National Correct Coding Initiative Guidelines. So number one, don't use a modifier if it's not appropriate or not needed. And then number two, if you do need a modifier, make sure you're submitting it on the original claim. Make sure your documentation will support that particular modifier. Then we have Field 11. Field 11 messes a lot of people up. It is your responsibility as a Medicare provider to determine who should pay first, whether Medicare's primary or there's another insurer that should pay before we do. Well, you enter that information on the claim. It's either going to be in Field 11 on a paper claim form, which obviously not a whole lot of people bill that way, or the electronic equivalent. If Medicare's primary, then you just enter the word none. If Medicare's secondary, that's where you're starting to enter the insurance information for them. If we don't have anything in Field 11, then unfortunately Medicare has to reject that back. So now let's talk about denials. Denials are where we did receive a claim, and we were able to make a payment determination, but we were not able to pay it. So the first one there is where the patient's in a managed care plan. This is a Medicare Advantage Part C. So when you're talking to your patients, number one, you want to make sure that you're getting all of their insurance cards. And then number two, use that self-service portal. Again, if you're sending it to us first, whether it's managed care, primary insurance, etc., then you're really just delaying your payment because then you have to figure out what happened and then have to either resubmit or request an appeal. The next thing that we have is hospice, and hospice is kind of really its own animal. A patient can elect hospice care when they have been diagnosed with a terminal illness with a 6-month or less life expectancy. Now, this is the patient's choice. They don't have to elect hospice if they don't want to. If, however, they elect hospice, then they're choosing not to treat whatever that terminal illness is. They're really choosing to receive the palliative care. All of this is explained to them. So they're understanding, they're not going to continue to receive treatment. All of their services should be coming through that hospice. Now, Medicare does pay in two situations. Number one, if it's the patient's determined attending physician, and that physician is not part of the hospice. So when the patient is completing the hospice paperwork, they say, oh, yes, Dr. Smith is my attending physician. So Dr. Smith can continue to provide care, and again, it's going to be palliative care related to that terminal condition. That patient-determined attending physician is going to submit their E&M services with that GV modifier. If you're seeing the patient and it's not related to the terminal condition, that's when you use the GW. Now, unfortunately, some providers kind of get caught in this because the family members will take them to get a second opinion, and they don't necessarily tell them that they have already elected hospice. That's why you want to use the portal. The hospice itself has 5 days in order to submit that election in to the Medicare processing system. So what happens in this situation? Well, Medicare doesn't make payment if it's related to that terminal illness, but you're not the attending physician. You would need to look to the hospice for payment of that service. Duplicate services, this one absolutely drives us crazy. Number one, you don't want to have any type of automated resubmits for Medicare. If Medicare is denying a service, we're saying we've already paid it or it's currently in process. You have to wait until Medicare processes that claim that you've already submitted before you determine what should happen next. Automatically resubmitting really kind of moves into a fraud or abuse type of situation because you are deliberately requesting duplicate payment from Medicare. So check if you have those automated resubmits. If your clearinghouse or vendor has those, get them to turn those off for your Medicare patients. You can evaluate your Medicare reports. The 999 report, when you're submitting electronically, will tell you that Medicare accepted that claim. And then you determine status either in the portal or using the 276, 277 HETS transaction. We also have provider eligibility denials. And again, this is very similar, but it's where we're determining that we can't pay the provider that you have submitted. That second bullet point there, the person billing can't do the service that was billed. For an example, a chiropractor can't receive payment for an E&M service. And then again, we go back to the multiple visits within a single day or multiple new patient. And depending on the information, sometimes it ends up in unprocessable, sometimes it ends in a denial. And again, if you're billing for non-physician practitioners, I encourage you to sign up for that 1121 webinar that we're going to be doing. Missing modifiers, we've kind of talked about modifiers already. You want to make sure if your E&M is part of global surgery, if it's part of the NCCI program, then evaluate your documentation first to make sure your service really is separately payable, and then use the appropriate modifier on it. Now, this one, denials for timely filing, is a little bit different. Your other denials, you have appeal rights. On this one, you do not. Medicare says that you have to submit a claim within 1 year from the date of service. If it's after that 1 year, Medicare will not pay it. There are some exceptions to that, but generally it is a Social Security problem, or it's an enrollment or disenrollment from a Medicare Advantage problem. That's pretty much it. If we deny it for timely filing, you can't collect from the patient. You can collect coinsurance, and you can see that on your slide, or any unmet deductible that would have been applied. The reason why we see this more than anything else is the patient had a primary insurance company and you submitted the claim to them, they paid you in full, and then you did not submit to Medicare. And now, more than a year later, that primary insurance company has taken their money back. Well, at this point, if it's more than 1 year from the date of service, you have no option. Medicare simply is not going to pay that claim, and you can only collect coinsurance and unapplied deductible. What you want to do when that primary insurance company pays you in full, submit the claim to Medicare. Couple of reasons for that. The first is administrative. Did you submit for an annual wellness visit? Well, we need that information back so then we can determine when the next time an annual wellness visit can be provided to that patient. And there's multiple other services that have frequency requirements. And so by you submitting that, even though it's paid in full, by you submitting that, that information gets into our processing system. And then the last one is your claim is in the door timely. If it's in the door timely, and then that primary insurance company makes that change, you still have options. You can still, there are some things you can do to still receive payment. We have information available on our website on what you would need to do for that. But it's in the door. And so we really encourage you, it's not requesting duplicate payment, because you're going to be telling us this is what the other insurance company allowed, this is what they paid. Medicare, if they paid you in full, obviously Medicare's not going to pay anything else, but then your claim is in the door. So that's kind of my advice to you on that one. So the next thing that we have then is just a listing of the resources. The first one on the right side of your screen there talks to you about documenting time in your medical records. Improper payments is listing there. On the CMS website, it gives you those CERT reports. We've got the Office of the Inspector General information, the Recovery Auditor information that we talked about. So the next thing we want to do is open it up for questions. Aline, do we have any questions in the chat?
We have received a couple questions, Ellen. I just put something in the chat because I did check while you were speaking, and that non-physician practitioners change webinar is open for registration if you go to our live events page. So I did drop that in the chat for those of you that were wondering about that. The first question that I have says, and this was early on when you were talking about critical care, if the provider states, and they have quotes, greater than 35 minutes of critical care provided. Is that allowed, or does it need to be a specific amount of time?
That can be allowed, however, it's not your best practice. For an example, if we were doing medical review on critical care and we looked at 25 of your claims and all 25 had that same statement, we're going to question that. We're going to come back to you on that. The best answer for that is your physician or practitioner needs to document their specific time that they spent on critical care or discharge management, for that matter, for that particular patient on that date. Next question.
All right, and our next question says, we have a provider in our practice that is notorious for not signing off on his encounters on the date of service. We try our best to get him to sign off on them in a timely manner, but some of them get to be over a month old. Are you saying he should be doing an attestation in these cases?
He has to do an attestation in these cases. He cannot add a late signature to the file. Medicare wants the signature on the date of the encounter or really within a couple of days, allowing time for a transcriptionist, a scribe, or a scribe in order to get done with that documentation. If it's after that, then you need an attestation statement.
Okay, very good. Thank you. That is all the questions that we have at this time.
Okay, wonderful. We will go on to our next slide then. Here in just a few minutes, you're going to receive an email from us that is your proof of attendance. Number one, it's going to have a survey link in there. So, again, we're encouraging you to take that survey. Also, though, at the bottom of this email, it's going to provide you with the certificate of achievement. So it will identify today's presentation, it will give you the date, and then the contact hours. This is what you can use with your accrediting organizations in order to request the continuing education units. Now, if you joined us by phone and you didn't sign into WebEx first, then you won't receive this email, obviously, because we don't have your email address in there. What you can do, though, is you can send us an email to the wps.gha.education@wpsic.com, and you can tell us you attended, excuse me, and then the telephone number that you used to call in. We will then evaluate the reports that we're going to get back from WebEx. If your phone number's on there, then we'll create a certificate of achievement for you. The next thing is that you do have 7 days following this presentation to submit any follow-up questions. Again, you'll submit that to our education email box, and that's listed there for you on the slide. In the subject line, you want to indicate today's topic, which is E&M common errors. Then the people who monitor that mailbox then will be able to send that to me so I can get a question back to you. We can't, however, take claim-specific questions. Our provider and outreach and education team, we don't have access to the processing system. So any claim specific, you will need to go to customer service. And then, of course, we've talked about the survey already. We do encourage you to take this survey. We're very interested in your feedback. What did you like about this presentation today? What could we have done better? Not only my presentation, but the materials that we provided to you. The survey also allows you to provide us with additional information. What education do you want to see us do in the future? We use that information to develop our education plans. We want to satisfy your requests as far as the education that you need. On the very right-hand side of your screen, you'll see that white box with the blue continue button at the bottom. Once you leave this webinar, then this is what will come up on your screen. And it's really WebEx telling you that we, your host, we want you to go to another screen. And that's going to be the actual survey screen or CMS survey itself. So again, you've got a couple of ways to do that. So on behalf of Aline and myself, we just want to thank you very much for your attendance today, for the questions that you provided to us. And again, I know I've mentioned it before, but we really are looking for your feedback in completing that survey. So that's all the information that we have for you today. Have an absolute fantastic day, and you can now disconnect.